مساء النور دكتور شرف أبو شرف، صباح النور دكتور وليد أحمر، مساء النور دكتورة مريان ودكتور شاهين. رح نبلش هيدي الحلقة الثالثة اللي هي الحلقة الأولى من سنة 2022 من سلسلة المحاضرات الطبية التثقيفية اللي هي منظمة من قبل الجمعية اللبنانية الطبية العالمية بالتعاون مع الجمعية اللبنانية لطب الأطفال، واللي هي تحت عنوان ما هو الجديد وما هي آخر الابتكارات في عالم طب الأطفال. واسمحوا لي أنه أعطي الكلام للنائب الدكتور شرف أبو شرف اللي راح يفتتح هذا اللقاء. دكتور شرف تفضل.
أنا أولاً شكر الدائم لكم بالإلما بالنقابة الأطباء بجمعية الأطفال على الجهود اللي عم تعملوها لحتى نضل رغم الظروف الصعبة اللي عم نقطع فيها بلبنان نحاول نكون up to date بالقضايا العلمية. بتأمل إنه هالسنة الجديدة بتكون خير علينا جميعاً، قاطعين بظروف لا شك جدا صعبة اقتصادية سياسية صحية اجتماعية، ولكن أنا مؤمن أنه بالتعاون والتضامن بين بعضنا وبالمشي على الخط المستقيم الخط الصحيح لابد ما نوصل. غايمة وقاطعة إن شاء الله ما تطول، ولكن كل الشكر لكم على هالمجهود اللي عم تعملوه بهالظروف هيدي. دكتور أحمر، دكتورة مجدلاني يلي من حييها عملت جهود جبارة بجمعية الأطفال بهالظروف الصعبة، وعنده الانتخابات قريبة بالجمعية لانتخاب رئيس جديد. مشكورة على كل شيء عملتيه دكتورة مجدلاني. دكتور بخاش كمان مشكور على المجهود اللي عم تعمله بجمعية CME. ونحن عم نحاول قدر الإمكان شو فينا نعمل، عم نعمل في شغلتين مهمين بحب أذكرهم هون. قطعنا باللجان النيابية مشروعين قوانين، واحد ضمان الطبيب مدى الحياة يلي إلا سنوات عم نباطح مشان وصار هلا بالهيئة العامة، والثاني حصانة الطبيب حتى ما يضل يتعرض للتعنيف الجسدي أو اللفظي، ويعاقب كل من يعتدي على طاقم طبي تمريضي صحي بالحبس وبالغرامة. بيبقى إنه نقدر نضل معكم بهالامور العلميه اللي عم بتقوموا فيها، وبتصور انه كتار عم بيكونوا عم بيشاركوا فيها ونفعها جدا كبير على الطاقم الطبي اللي عم يشتغل بلبنان. برجع بقول بظروف صعبه. بجدد شكري لكم وتهاني على الامور اللي عم تعملوها.
دكتور شرف، بدي أتشكرك على هذه المداخلة، وما في شك كلنا بنتشكرك على الجهود اللي قمت فيها واللي بعدك عم بتقوم فيها للوقوف إلى جانب المجتمع الطبي وحماية الطبيب بممارسة هذه المهنة الشريفة. وهلأ بدي أتوجه لدكتور وليد أحمر اللي هو رئيس الجمعية اللبنانية الطبية العالمية لافتتاح هذه الحلقة. دكتور وليد, the floor is yours.
Thank you, Dr. Yusuf. Good evening, good morning, good afternoon to all our doctors throughout the world, our ILMA colleagues, in particular our colleagues within Lebanon. Lebanon, as Dr. Sharaf has rightly said, is going through a difficult period of time and has been for a number of years. ILMA wants to assist all our Lebanese colleagues in Lebanon with this educational series. We want to bring the best of all the doctors we have around the world and to collaborate together and to continue to do so. This is our third series of updates. We will do it in pediatrics. And I want to thank Dr. Maria Magdalani for everything she has done in helping bring this to fruition. Also, Dr. Yusuf and Dr. Sharaf for all their support. We hope that you gain benefit from listening to this webinar. We are excited to continue to collaborate with our colleagues within Lebanon. It is important. Education is a key, and collaboration is also very important. We learn from you and you learn from us. And hopefully we can continue to partner each other, and hopefully we can navigate the difficult period that the doctors within Lebanon are facing. And I look forward to this webinar and further webinars throughout this year. Thank you, Dr. Yusuf.
Thank you, Dr. Ahmar. And I would like to take this opportunity to thank you again, and to thank ILMA, the International Lebanese Medical Association, for your involvement in the organization of these educational series. أما الآن فاسمحوا لي أنه أتكلم باسم لجنة التثقيف الطبي المستمر بنقابة أطباء لبنان ببيروت، وأتمنى لجميع الزملاء عام سعيد. هلا إذا بدنا نقيم السنة اللي فاتت علينا، يعني سنة 2021، ما فينا إلا نتذكر هيدي العاصفة، جائحة الكورونا اللي عصفت بالعالم وبلبنان مع كل تأثيراتها الجانبية الاقتصادية والمالية والصحية والمهنية. وبعد هيدي الجائحة مع الأسف ما انتهت مع الموجة الرابعة والخامسة من جائحة الأوميكرون. أما الموضوع الثاني اللي بحب أجي على ذكره، واللي هو داخلي للبنان وبخص المجتمع الطبي، وهو هيدي الظاهرة وموجة الهجرة الطبية اللي عم نعيشها، وهجرة الأطباء اللبنانيين إلى الخليج العربي، إلى أوروبا وإلى أمريكا. هيدي المحاضرات وهيدي اللقاءات الافتراضية يمكن اجت بوقتها لحتى تقدر تحافظ على هيدا الرابط ما بين الداخل والانتشار الطبي اللبناني، لتسلط الضوء على قدرة الطبيب اللبناني انه ينخرط باي مجتمع بينوجد فيه، وانه يساهم بطريقه مباشره او غير مباشره بتطوير العلم والطب باي مؤسسه عم بيشتغل فيها. فاجت هيدي المحاضرات كمان لحتى تحافظ على الرابط ومساهمه هؤلاء الاطباء الموجودين بالانتشار بالعمل العلمي والتثقيفي الداخلي بنقابه اطباء لبنان ببيروت، واللي بتخول لكل المشاركين والزملاء انه يستحصلوا على نقاط تثقيف طبي مستمر. بدي اتقدم هلا من الدكتوره مريان مجدلاني، اللي هي رئيسه الجمعيه اللبنانيه لطب الاطفال، لتقدم وتفتتح هذه المحاضره. دكتوره مريان تفضلي.
دكتور بخاش، أنا بشكرك على التعريف. أنا on behalf of the Lebanese Pediatrics Society ببيروت and my colleague Dr. Ziad Qas'a the Lebanese Pediatrics Society North really would like to welcome you all to what looks and promises to be a very exciting webinar. This is our first collaboration with ILMA, and I'm looking forward to further collaborations after this first webinar. Dr. Ahmar, I cannot thank you enough for what you have done, for all the efforts in organizing and collecting and inviting these top-notch speakers to our webinar tonight. Dr. Bakhash, cannot thank you enough for the efforts in bringing us together for the purpose of science and connecting all Lebanese across all continents, which we are very proud of, that we are present everywhere and bringing Lebanon's name forward in every possible way. نائبنا، أنا بشكرك على دعمك الكامل لجمعية طب الأطفال. كانوا سنتين منن هينين أبداً، بس وقفنا مع بعض، وإن شاء الله نضل مسابرين على كل الجهود اللي عم نعملها. Again, welcome all and looking forward to this exciting webinar.
So again, I am going to introduce Dr. Marian. She is professor in pediatrics, Marian Majdalani, at the American University of Beirut Medical Center. She is also the president of the Lebanese Pediatric Society. And thank you, Marian, for moderating today this session.
My pleasure. Thank you.
Dr. Walid, if you can introduce the other moderator, please.
Thank you, Dr. Yusuf. I have the honor of introducing from the United States of America, Dr. Naif Shaheen. Dr. Naif is an assistant professor of pediatrics. He's a member of the American Academy of Pediatrics, and in 2019 he was elected Academic Pediatric Association Research Scholar. He is an associate program director of intern recruitment for the Department of Pediatric Residency Program and is a member of the VCU School of Medicine, Neonatal and Perinatal Fellowship Advisory Committee. Dr. Shaheen also serves clinically as an attending faculty at the Children's Hospital of Richmond. He's involved in neonatal invasive care unit and neonatal continuing care program. Dr. Shaheen, thank you, and it's an honor to have you with us and co-moderating with Dr. Marianne tonight.
Thank you for the opportunity. I should have made that introduction shorter. Thank you, though.
Shall we introduce our first speaker? I'll leave it to the moderators.
Yes, we can go ahead and do so. Well, thank you everybody for joining us today. Really, really exciting to see everybody come together again, as mentioned previously, for bettering science and helping our colleagues back at home and continuing with our education and so forth. Our first speaker on the agenda will be Dr. Manuel Rahman, who is our Lebanese, a graduate of the Lebanese University, and currently pediatric cardiologist and pediatric cardiac intensivist at Mass General Hospital in Boston. Today, she'll be talking to us about respiratory distress issues in pediatrics, and we thank you for your time and presence today.
Thank you so much, and thank you for the opportunity to meet or to see old colleagues and meet new ones all over the world and in Lebanon. Can I share my screen?
Yes, please go ahead. And just a friendly reminder to everybody, and just to allow our speakers to give us a lecture uninterrupted, if you could all just be muted. And if you have any questions, feel free to add them to our chat. And when the time comes for questions, if you want to unmute at that point in time, that'll be fine. Thank you.
I was asked to talk about emerging respiratory viral infections in children, and I wanted to rename the title actually to looking backward and looking forward. And it's kind of a journey of a pediatrician in the past few years, especially in the last 22 months. Acute respiratory infections worldwide are a major health problem, especially in young children and elderly. The symptoms are the same. The viruses are easily transmissible and lead to high morbidity and mortality. According to the WHO, in 2015, acute respiratory infections were responsible of 1.8 million deaths in children less than 5 years of age. And things haven't changed 22 months ago. The most common causes of acute respiratory illness in children in the first decade of the 2000s were RSV, followed by human metapneumovirus, influenza, parainfluenza, and things did not change in the second part of the second decade. And usually the treatment were basically supportive, and when patients would be admitted to the hospital, we would treat them for bronchiolitis, and very rarely those patients would need antibiotics and other support. However, 22 months ago, the world stood still when a global outbreak of SARS-CoV-2 happened. And we started seeing all over the world adult patients being admitted with high mortality of patients who were admitted to the hospital and high morbidity, either respiratory failure, acute kidney injury, myocardial dysfunction, and myocarditis. However, its impact on children was different. Thus far, nearly 2 million cases of SARS-CoV-2 infections in children were reported, but it's likely an underreported number of infections, especially in the last few weeks. It caused nearly 9,000 related hospitalization and approximately 1,000 pediatric deaths. But if we compare the ages of 5 to 11 years, we noticed that the death toll was higher than the average death per year caused by other infections. However, we know as pediatricians that the impact on children was very mild. On a study, meta-analysis of studying more than 2,200 patients who had COVID-19, more than 92% of the cases were asymptomatic, and 8% of those children had some symptoms. The main causes of symptoms were fever and cough, very mild respiratory or upper respiratory infection or GI symptoms. When we look at the symptomatic patients, we classified them as mild COVID, moderate, and severe. And the mild COVID symptoms were actually also the most common. Those had sore throat, congestion, fever. The moderate symptoms had mild pneumonia, but did not require to be in the hospital. They had muscle aches, headaches, fever. And when those symptoms progressed to need for hospitalization, then those were the severe COVID. And those only comprised 6% of the cases. So the pandemic hit, we didn't see a lot of sick kids. However, 2 months later, so in May of 2022, some reports started emerging in Europe, and this report came or was published describing a phenomenon that is associated with COVID-19. There's a temporal association between an infection and the onset of this syndrome. And 14 centers in Europe described 35 patients admitted in cardiogenic shock to the hospitals. Those patients had signs of Kawasaki disease with high fevers for at least 4 days, conjunctivitis, mucous membrane changes, lymphadenopathy, skin rashes, and most of those patients had cardiac dysfunction and coronary dilation. That was really more than what we would see with Kawasaki disease. So the term of multi-inflammatory syndrome in children associated with COVID-19, or MISC, was then described or coined by the CDC. And actually, the criteria are any child between 0 to 21 years. But although, as you guys know, there is an MISA, so this syndrome is described also in adults, but it's mostly seen in children, where you only need 1 day of fever and evidence of 2 organ system involvement, in addition to lab evidence of elevated inflammation. Those are elevated CRP, elevated D-dimers, ferritin, IL-6, and usually you should exclude other causes, and you have to have some history or contact with someone with COVID. So the child was exposed to COVID in the preceding 4 weeks prior to the onset of symptoms, or evidence of an infection like either SARS-CoV-2 positive PCR or serology. A study actually studying reports of MISC between March and June 2020 had described 783 cases, and usually the median age is 8 years. Usually those patients are not sick. They don't have any comorbidities except few. And usually the morbidity associated with this is obesity. A lot of the patients had GI symptoms, Very rarely we've seen respiratory distress, but we've seen cardiac findings, either tachycardia, hypotension, or cardiac dysfunction. And the lab were remarkable for high CRP and high neutrophils, low lymphocytes. In this study, 59% had either positive SARS-CoV-2 serology or PCR. However, in the US, thus far, 6431 patients have been reported with 55 deaths, but 98% had a positive test of a previous SARS-CoV-2 infection. The study that I mentioned only reported 1.5% death. So despite that SARS-CoV-2 can cause MIS-C, the death toll is very low. We have seen problems, late-term problems with SARS-CoV-2. Long-term complications include also long COVID or long haul COVID. It has been described mostly in adults, in young adults, but we've seen it in our teenagers. Those patients have persistence of COVID-19 symptoms between 3 to 15 months after having COVID. They are fatigued. It's called chronic fatigue syndrome. They're also dyspneic with minimal exertion. They have tinnitus, dizziness. They have severe disconditioning and deconditioning and dysautonomia. So we've seen those problems, and let's not forget about the non-medical and indirect effects of COVID-19 in children. COVID-19 had really caused an increase in mental and behavioral health issues. We've seen higher anxiety level and higher depression with suicidal attempts in our adolescents. There have been disruption in education, disruption in social and emotional development, increase in obesity, which is a different pandemic. There were a lot of financial impact on families, and in the US, we've seen loss of safety net resources. A lot of pediatric children from low socioeconomic status relied on having breakfast and lunch at school. And when they stopped going to school, they lost that. So there was also an increase in abuse and neglect in those families. When pediatricians were not seeing a lot of patients in the beginning of the pandemic, when people were social distancing, wearing masks, then we saw also a decrease in other viruses. However, when kids started going back to school but still wearing masks, we started seeing emergence of other pathogens and containment of other pathogens. The study that occurred from November to April 2021, which is basically the winter, actually mimics what we've seen in at least Massachusetts. We saw a higher rate of rhinovirus infections affecting even kids who are older, shouldn't have been sick, and they were even admitted to the hospital. And we did not see RSV, metapneumovirus, and influenza initially. However, when they started, when the quarantine or isolation was relaxed, we started seeing an emergence of RSV during the summertime, which usually is not seen. And we started seeing older patients with 2 or more viruses being admitted to the ICU with bronchiolitis. And needing and requiring non-invasive positive pressure ventilation or even positive pressure ventilation. So what we typically do is usually for bronchiolitis is supportive therapy, as I mentioned before, and we follow the respiratory assessment score, which is called RAS, and depending on that, we kind of tailor the therapy. And we basically we're seeing a lot of patients being admitted to the hospital that shouldn't have been admitted, or would not require admission with those viruses before the COVID pandemic. We thought we knew what we were doing, but then other things started happening. A month ago, another variant kind of emerged other than the Delta. It's the Omicron variant. And up to New Year's, 80% of the COVID samples in our hospital or in Massachusetts were basically Omicron, but last week, 93 to 95% of all of those samples are Omicron. So it looks like Omicron is taking over, and but we're still seeing in our ICU the effects of Delta with patients admitted having comorbidities and being admitted to the hospital or to the ICU. As of yesterday, there were more than 308 million cases, confirmed cases, and the vaccine doses are still not up to par, I would say, worldwide. However, we're learning from our colleagues, from the adult colleagues, and that's what has been really amazing to see in the pandemic. What we've learned from South Africa is that the number of cases is really on the rise, but this is different from the number of hospitalization or the number of deaths with the Omicron variant. And this is certainly, those peaks are different from the prior surges with Delta and other variants. What we've also learned from the UK is that the death rate is much, much lower than the number of cases and the patients admitted. And the use of ventilator really is so low compared to other surges. In the United States, we are behind. We are behind 3 weeks behind the UK. Data from New York is showing that we're seeing really a lot of patients. The sheer number of patients having COVID is very high, and the number of hospitalized patients is way higher. But the number of ventilated patients is lower than the previous surges. And it's likely due to the less targeted vaccine strategy in the US compared to the UK or other places. Overall, in Massachusetts, we're seeing a higher number of patients having positive COVID testing. As kids go to school, or they're going to go to school after the holidays, it's a perfect storm because we have a highly transmissible Omicron variant in children who are not vaccinated, and around unvaccinated adults. And I think that problem is going to be also in Lebanon and other countries. However, we can tell you that the risk of complications remains the same. So what do we want to tell our patients and families? We basically, as pediatricians, we have learned a lot in the last 22 months. We have a lot of data, but we cannot compare to other diseases because things keep changing, and we just have to emphasize on the positive. We will be done with the pandemic when the virus becomes endemic, and this is with vaccination and public health intervention. We should not forget the 8% that I talked about that might have some complications to COVID or MIS-C or long-term complications with COVID. So it's not just let's let them get COVID and be done with it and move on, because we have seen some cases of complications in children, and we emphasize on the efficacy and safety of the vaccination. We have seen in the COVID era, and likely they will touch base on that, but the risk is very low. What do we do for patients who are admitted for COVID? So we kind of extrapolate from the adults. There is a clear-cut kind of management in adults with COVID-19 from the NIH. And what we do for our patients who get admitted, usually supportive care. But if someone is admitted for moderate symptoms or severe symptoms, they get remdesivir. There are some reports that remdesivir might not be working for the Omicron variant, but those have not been published. We still give it. And if they need oxygen, we give steroids. And supportive care if they have any other complications. Monoclonal antibody therapies we offer for patients who have high risk and before they get admitted. There are no pediatric specific data. We know that sotrivimab is on national shortage in the US, but it is effective against the Omicron. The others are not. And we are still studying the Regen-CoV. When we do that, we actually have to, so we offer it, at least in our institution, we offer it for patients who have either immunosuppression, they're immunosuppressed or organ transplanted on immunosuppressants. And so they qualify as high risk if they have COVID. When someone gets admitted with MISC, it's usually a multidisciplinary approach. We have a daily Zoom conference with cardiology, ID, rheumatology, hematology, and the primary care team. And if those patients who are admitted meet criteria, then they get IV gamma globulin at 2 per kilo, they get steroids, and we follow the recommendation from the American Rheumatologic Society. And we use either 1 to 2 grams per kilo, but if they have cytokine storms, high IL-6, then we use higher doses with pulse therapy for 3 days. If the platelets are above 100,000, we use aspirin. And if the D-dimer is 5 times the normal, we use anticoagulation with low molecular weight heparin. We follow coronary dilation and cardiac function every day until it stabilizes. And we closely follow them for the first 2 months, very slow taper, a taper of steroids, and then follow them later as well. There are other antivirals that are coming up. I can say that there is a new pill on the market, but we are still waiting for the FDA label and how to use it in children. The important thing to know about the anti-COVID pills are that it allows us to hit early and hit hard and stop the virus in its tracks while it's still in the infectious phase. So usually it's used earlier in the disease, but we don't have a lot of studies in children. I'm not going to talk about vaccines, and I'm going to kind of give you some learning points about this. We know that COVID in children has some complications. There are novel therapeutics for acute COVID-19, including both monoclonal antibodies and antivirals. And usually we just have to, I think the few next month will tell us which patients will benefit. Would they be the non-vaccinated children, high-risk children, who have more than mild symptoms? So the future will give us some idea. And COVID-19 endgame will require a multi-pronged approach, including vaccination, evolving public health intervention, and ongoing education for the parents. I want to also make sure that you take precautions with this highly infectious virus, because we have seen a lot of the healthcare workers having the virus and being out of commission, and you have to take care of yourself to take care of your patients. Thank you so much for the opportunity to give this talk, and I'll be happy to take questions later.
Well, Thank you so much, Dr. Ahmed. Actually, we will be taking questions after each speaker. So if anybody has any questions for Dr. Ahmed, please feel free to either type it on the chat or on mute. But we appreciate your topic, and again, I think as pediatricians, you know, advocating for our patients is always going to be our priority, and you know, we are challenged in the fact that, you know, conducting research in peds is not as easy as it would be in adults. So trying to extrapolate a lot of the data that we learn from the adults into pediatrics is not always feasible, right? As you know, we know that they're not smaller adults, their physiology and bodies are just different. You know, being a neonatologist, you know, thankfully, I would say we haven't seen much of this thorns and sickness as some of you might seen out in the older kids. But I guess what I'm getting to with this is, are there any specific, I guess, factors or conditions that you have seen or has been put out there that would certainly qualify a kid, other than the immunosuppression, you know, that would sort of classify a kid as a higher risk to end up, you know, developing the storm or sick in the ICU and requiring ventilation?
Thank you for the question. What I can tell you is that for acute COVID infection, we have seen patients who are adolescents or even older children, 9, 10, 11 years, who are obese, and older adolescents who are either have asthma or smoke or vape. Those will end up in the ICU and some on the ventilator. And we were and we've placed some patients on ECMO for COVID, acute COVID infection. As for the MISC, we have not seen any risk factors. Usually those kids are healthy. They had COVID, either asymptomatic or very mild symptoms, and then they present 2 or 3 or 4 weeks later with fevers, without any other cause. And sometimes we have to admit them for a few days to kind of have all of those criteria and decide on treatment to exclude other causes. And I'm talking now for the Delta variant. So our experience with the Delta variant is that kids who have obesity, hypertension, or smoke or vape have high risk, just like the adults. And who end up on the ventilator have chronic lung disease, or they have a trach or other problems, and they end up in the ICU. But for MISC, we have not seen a lot of risk factors or comorbidities associated with it.
Perfect, thank you. A few questions in the chat. So one is asking about our experience with neonatal COVID infection and it presenting as neonatal respiratory distress syndrome. Not sure if. Go ahead.
I can take a swing at this question because we have seen in our institution some neonatal COVIDs. However, usually they're not sick, and those are because the mother was sick and she transmitted it around the birth. So usually those babies are really observed and they don't have a lot of symptoms. There have been some reports of patients admitted postnatally when the mother had COVID for 2 weeks preceding that, and they had some coronary dilation or cardiac dysfunction, but this was 1 or 2 reports. So we have not seen that. Certainly, if we see a baby with COVID with some respiratory distress, they received remdesivir and steroids, and likely that hastened their recovery. But I would also now turn this to you, Nai. If you're a neonatologist, have you seen that in your institution?
Yeah, no, thankfully we have not seen that. Again, a lot of the kids that we've admitted to our NICU that have presented with respiratory distress, and among who's been COVID positive, those kids have actually turned out negative when we test them. which leads to thinking of other diagnoses. And the babies that we've had that have turned out positive, most of them have been, it hasn't been at birth. They were exposed at some time to other stay in the NICU and became positive either because of staph exposure or parental exposure. But again, they have remained asymptomatic. So it's a tough situation because, as we know, respiratory distress syndrome can be caused by a lot of things depending on the age and prematurity and so forth. But then you wonder about hypercoagulability, like you will see with other cases and so forth. And again, we have not seen this. There is actually data being collected at a national forum by all NICUs and trying to hopefully put out some more information out there for people to be able to be better guided with this. Another question in the chat is related to whether vaccines are recommended for children 5 years old and above. I would say that currently that is the approval age for us.
Yes, so COVID vaccine, mRNA, the Pfizer has been approved for 5 to 12, and it's actually in the US that has been given. The boosters have not been approved for that age group. The boosters have been approved for 12 years and above. It has been approved like a week ago, or 2 weeks ago, I'm sorry. FDA approved, and then the CDC kind of granted that approval for above 12.
Exactly, and there's actual trials going on right now to enroll younger kids, and hopefully we'll have the data out there for neonates up to the 5-year-old cutoff. One question relates to the limitation of obtaining IVIG in Lebanon. There's questioning whether there's any studies that have shown only the benefit of using steroids for MIS-C. Again, since a lot of families unfortunately won't be able to afford IVIG.
That's a very important question. And if you read the studies about MIS-C from New York and also New York and also multi-center study that came out in circulation, the use of the treatment of MIS-C is not kind of straightforward. And there are very mild MIS-C who do not require any treatment as the inflammatory markers go down. And there are centers who only use steroids and watch. In our institution, we follow the recommendation from the American Academy of Rheumatology, and we use steroids in combination with IVIG. Some people also use anakinra or other immunosuppressants to kind of decrease that cytokine storm. So it's very reasonable if you have moderate symptoms without cardiac dysfunction to only use steroids and wait.
Thank you, and I will do one last question so we can move on to the next speaker, which relates about the incidence of MIS-C, it being less with the emerging variant.
Unfortunately, we don't have enough data to kind of support that because the Omicron is kind of new, especially in the US. I can tell you that in our institution, we're seeing after Christmas, after Thanksgiving, which is in the end of November, we saw a surge of patients with MIS-C. And then after Christmas, we're seeing another surge of patients with MIS-C. We have 2 or 3 patients admitted every week to our hospital. So we still don't know if this is due to the Delta or the Omicron. And I think the next few months will let us know.
All right, well, we thank you again, Dr. Lahoud Rahmi, for your time and great presentation. And we'll move on to our next speaker.
Okay, thank you, Dr. Naif. So it gives me great pleasure to introduce Dr. Elia Malouf, who is a highly qualified general pediatrician and neonatologist with a wealth of experience and expertise in brain injury in preterm and term newborns. So Dr. Malouf is based in London. He's a consultant at Homerton University Hospital and at Portland Hospital for Women and Children. So after obtaining his primary medical qualifications at the University of Dundee in Scotland, he embarked on his specialty training and got his doctorate in medicine with his thesis centered on brain injury in preterm infant. Dr. Malouf is currently the editor-in-chief of Early Human Development Medical Journal. We welcome you on board, Dr. Malouf, and we're looking forward to your talk, which will be whole body cooling for asphyxiated newborn infants.
Thank you very much, Marianne. That's a very kind introduction. I'll share my screen, and we will be moving from the topic of the hour, which is COVID, to a condition that has been with us for a very long time and will continue to be with us for a very long time, the sad condition of asphyxiated newborn infants. So I just want to touch on the issue of cooling and just concentrate. Can you all see my slides, actually?
No, we cannot.
I'm very sorry. So do I have the ability to share my screen?
Yes, you do. You should.
Okay, I will.
If you're not able to,
I will try again.
Yeah, I was going to suggest if you want to send us your slides, and I'm happy to share it from here and guide through the presentation.
Share. I'm going to say share. Is that?
Yeah.
Is that any good?
Yeah, we're good.
Lovely. So if I go to slideshow, can you still see everything now? Excellent.
Yes, it's perfect.
So I'm just going to concentrate on one specific topic, which is asphyxiated newborn infant and the use of whole body cooling. And then maybe we can go on to discuss what we do in Lebanon. Are we cooling asphyxiated newborn infants, etc. So the first part, I'm just going to talk about what actually happens when asphyxia occurs, and we must always bear in mind that a newborn infant has a lot of other complications and not just the mechanical asphyxia. But if we just assume for a minute that a newborn infant behaves as an experimental animal, then I'm going to just go over the whole process of what happens. The minute of an insult happens, then we go through a process of a sort of primary energy failure. So in experimental animals, this is the minute or the second that the internal carotid artery is tied off and an asphyxia is induced. The primary energy failure at this stage, we have necrosis and cell death through the process of necrosis. We then, at this stage, the baby, if we leave the baby alone, then we may well lose the infant or the experimental animal. But if we do resuscitate at this stage, then what we have discovered through experience is we have a period of time before secondary energy failure sets in. And the secondary energy failure can set in from 6 hours up to many hours after the initial injury. During the secondary energy failure, cells, as opposed to dying by the process of necrosis, cells die through the process of apoptosis. So what actually happens at the minute when asphyxia happens? So we have activation of the N-methyl D-aspartate receptors at the surface of the cell. We have influx of calcium and activation of nitric oxide synthase. everything goes through mitochondrial dysfunction, and it's through mitochondrial dysfunction that this process leads to apoptosis and necrosis, lactic acid production, and edema. So we always talk about energy failure and energy levels, but the question is, how does one determine the energy state of a brain cell? And we do that through magnetic resonance spectroscopy. And magnetic resonance spectroscopy is the process of obtaining peaks and troughs of metabolites rather than an image when we put a baby in the scanner. So there are two types of magnetic resonance spectroscopy. We have the phosphorus spectrum, and in a normal 35-weeker term, 6 month and adult, this is the phosphorus spectrum that one would obtain. And as we can see, there is a tiny little peak of inorganic phosphate. This is in a 35-weeker all the way there. The other peaks are well defined as well. But it's the inorganic phosphate that's most important. If we go through the proton spectrum, and in a normal proton spectra, we see a tiny little bit of lactate peak in a 35-weeker, which then disappears at term onwards. The other peaks are N-acetyl acetate and phosphocreatinine. So if we actually scan an asphyxiated newborn baby, and we take the spectra from the basal ganglia, this area here, we actually, during an asphyxia or after an asphyxia, we see a huge peak of inorganic phosphate to phosphocreatinine. And we also see a huge peak of lactate taken from the basal ganglia. So I just want to go over the history of how we got to cooling as a treatment for asphyxiated newborn infants. There were a lot of experiments done, but I'll just summarize a few on rat pups and on piglets. And on this graph, we have asphyxiated rat pups. That 0.0 there is where we have the tying of the internal carotid artery. And we see this is the PCR to PI ratio as a measurement of energy state of the cell. When asphyxia happens, we have a huge drop in PCR to PI ratio. So there is energy failure. And this is the primary energy failure that I talked about in the very first slide. The rat pups are resuscitated at this point there. And we continue measuring the PCR to PI ratio. And we see that the rat pups, their energy state of the cells recover. And then, despite continuing to receive full measures, resuscitation measures, in the asphyxiated group, which is the dark circles, we see again a loss in the PCR to PI ratio. So these rat pups are now developing secondary energy failure. The open circles are rat pups that underwent sham surgery as a control group. And we have exact same picture in piglets. So what we know here is that the definition of primary energy failure and secondary energy failure. So what about the inorganic phosphate peak? And this is now in infants. Dr. or Professor now, Dennis Azzopardi, is the principal investigator that ran the cooling study here in the UK. And if you look, this is a spectrum done in a baby. This is a baby that was born asphyxiated, and Professor Azzopardi took this baby at the age of 8 hours and put baby through the scanner and did the spectroscopy. Peak 2 here is the inorganic phosphate, and this is the age where baby has been through the primary energy failure and is now back to normal energy state of the cell. And the same baby in peak 2 is there, there, and there. We saw that by 55 hours, we now have secondary energy failure that has set in. So does it matter, this primary energy failure and secondary energy failure of brain cells? We then went on to do studies on what happens later on in life to asphyxiated newborn infants. And this is a graph that represents babies that were normal and abnormal and those that died. And we see that babies that were neurologically abnormal at 18 months had the lower PCR-PI ratio measured on spectroscopy. And again, this is work by Professor Azzopardi. We also know that their mental development is closely associated with the lactate to creatinine level at birth. So what we've showed through animal studies and through studying asphyxiated babies is the importance of lactate to creatinine ratio and of the PCR to PI ratios. So if the first part was dealing with what actually happens when a baby is asphyxiated, the next part is what do we do at the bedside to try and identify those infants that are at great risk of asphyxia. And of course, the most important thing is clinical examination and staging of the HIE. Stage 1, where a baby is hyper alert. Stage 2, when we have some neurological abnormality. And stage 3 is the moribund infant. And this is the Sarnat and Sarnat staging that was published in 1976. And even at that stage, it was a clinical and electroencephalographic study telling us that encephalographic investigations are extremely important in diagnosing the level of brain asphyxia and the prognosis. So then we experimented with cerebral function monitoring. The very old monitor is shown there, the second stage monitor, and the current monitors that we use at the moment. And cerebral function monitors, I'm happy to take any questions about that and the usefulness of that, but basically it gives us a compact EEG plotted on a logarithmic paper. And what we expect with a normal CFM is for the bottom line to be above 5 megavolts and for the top line to be above 10 megavolts with sleep-wake cycle. We then go on to abnormal CFMs, and this CFM is showing a normal amplitude, which is where the bottom line and the top lines are, with some seizures. We can also have a moderately abnormal CFM, which is an abnormal amplitude with the lower line below 5 microvolts and the top line above 10. So this is a moderately abnormal CFM. We can also have moderately abnormal CFMs with seizures. or we can have severely abnormal CFM, and this is a CFM where the bottom line is near zero or definitely consistently well below 5 microvolts. So CFM, we can have severely abnormal CFMs with seizures as well. So CFMs are very useful bedside tools that can tell us whether a baby is at risk of long-term death or severe developmental disability. If we actually look at the CFM and its sensitivity, specificity, positive predictive value, and negative predictive value, is a very strong measure of death or severe developmental disability in severely asphyxiated infants. And a combination of a neurological examination shortly after birth with a CFM would then give us a specificity of 94% and a positive predictive value of 84%. What about imaging of asphyxiated newborn infants? We recommend imaging to be done after 7 days of life, because in the first few days we have a lot of cerebral edema. And what are the things we look for at imaging? We look for one single sign that is extremely important, which is an absent posterior limb of the internal capsule. So this is a normal brain MRI of a term baby. And we see that we always have a nice bright line there, which is the posterior limb of the internal capsule. And the absence of this sign is almost 100% predictive of death or severe developmental disability. Later on in asphyxiated babies, we see lots of damage in the basal ganglia and an increase in the CSF space, indicating some atrophy of the brain. So, why did we come to hypothermia? If we go to the same experiment that I talked about earlier, and now add a third group. So we have the sham surgery, the asphyxia group, and now we have added a third group, which is the hypothermia group, that we see in the hypothermia group that they lost their PCRPI, so they had their primary energy failure. The energy state of the cell recovered, and then it stayed the same. So in experimental animals, we managed to prove that the energy state of the cell can be maintained if an experimental animal is cooled immediately or as soon as possible after the asphyxial incident. And after the experimental animals are sacrificed, we managed to see histologically that there is preservation of most areas of the brain. We then went ahead and did some safety studies to show that we can actually do whole body cooling safely. And then in the UK, we embarked on a study called the TOBY study, which is the total body hypothermia and asphyxiated newborn infants, where our hypothesis was that prolonged whole body cooling in a perinatal asphyxia reduces death and severe development. So this was our primary aim, death or severe developmental disability. And the objective was that 72 hours of cooling can reduce our primary outcome and to confirm the safety, of course. We then went ahead and recruited, the aim was to recruit 236 infants over a period of 5 years. And we were looking at this was the sample size based on an estimated event rate of 70%. So we assumed that if we have clinical evidence of asphyxia with an abnormal CFM, that 70% of those babies will either have death or severe developmental disability. So what was our criteria and these are still the clinically used criteria at the moment. The criteria was a baby who's more than 36 weeks of gestation, which had one of the criteria A, which is an UPGAR score less than 5, continued need for resuscitation at 10 minutes, a cord arterial pH less than 7, or a base deficit of more than 16. So the baby must have one of criteria A plus one of criteria B, which is any kind of neurological abnormality, lethargy, hypotonia, reflexes, absent or weak stalk, or seizures. For the trial, we also applied the CFM for 30 minutes, and we looked for any abnormality in the CFM. The whole body cooling at the moment, we use machines that detect baby's rectal temperature and deliver the cooling through a whole body cooling through a blanket in order to maintain the temperature around 34.5 degrees C. Before our study reported, before Toby reported, there was an American study, which was the CoolCap study, and that reported before Toby. And in the CoolCap study, which had a similar recruitment criteria and a similar outcome, but this was a brain cooling study, a head cooling study, not a whole body cooling study. 2, 3, 4 infants were recruited with an abnormal CFM, half cooled and half conventional care, and 2 and 8 were followed up until 18 months. The primary outcome, which is death or severe developmental disability, was not significant. There was adverse primary outcome with the moderate CFM abnormality. So now if we take just the group without the severe abnormality, just the moderate CFM abnormality, the CoolCap study reported a significant reduction in death or severe developmental disability in the moderate group. We then have the Toby results, where we enrolled internationally 325 infants. Again, our primary outcome, and the study is only powered to look at the primary outcome. The primary outcome of death or severe developmental disability was not significant. If we look at severe disability only in survivors, again, the outcome was not significant. If we look at the developmental score in survivors, we did have a significant outcome. If we look at gross motor babies that survived without any abnormality, we had a significant outcome. If we look at severe disability, cooling again seemed to reduce that. But the most important thing is that our primary outcome was not significant. Now, we had 3 international studies at the time, and each single study, the Toby and the CoolCap and the ANI-CDH study, they all showed the primary outcome not being significant. That is only when we studied all 3 studies in a meta-analysis, suddenly the primary outcome of death or severe developmental disability at the age of 18 months became significant. And based on this meta-analysis, it is now recommended through, we call it here the NICE, which is the National Institute of Clinical Excellence, which is equivalent to the regulating body, basically, that all asphyxiated babies who meet criteria A and criteria B, not necessarily with a CFM, as long as we have one item from criteria A and one category from criteria B, that these infants should be offered whole body cooling for a period of 72 hours. Now, we may think that cooling, one thing that came out from Toby, which is extremely important, is the subgroup analysis and the time of randomization. What we found is babies who were randomized in less than 4 hours, the relative risk was significant. In those that were randomized more than 4 hours, the relative risk was not significant. But please remember, these are subgroup analysis and not the primary outcome. For cooling, at the moment, we know that the numbers needed to treat is 7. So with babies, we need to treat 7 babies of moderately or severely asphyxiated babies in order to prevent 1 death or severe developmental disability. I always like to show this slide because we sort of think that cooling is something that was recently invented, but it really was not at all. Because in the Russian literature, for example, in 1985, they talk about cooling asphyxiated preterm infants. In the old Western literature in 1962, there were papers about hypothermia and transfusion with oxygenated blood in the treatment of asphyxiated preterm infants. What actually stopped us from cooling infants and we started warming is one single randomized controlled trial, which is excellent, but it mainly dealt with preterm infants. So I'm happy to stop here and take questions.
Thank you, Dr. Dr. Malouf, for this amazing and very informative scientific talk. If there are any questions, please can you put them in the chat box, write them up.
Professor Marianne, we have Professor Celine Karam. She's at the airport in will board a flight in about half an hour, but can we have her talk first and then we'll come back to the questions?
And we will come back to the questions at the end. So
you.
I would let my colleague introduce her. Absolutely.
Yeah. Okay. We'll have Celine with us shortly, but Naif, I'll let you introduce her.
Perfect. Thank you. So our next speaker for today, if you just give me 1 second. Make sure I got it right. So it's Dr. Celine Karam. She's a pediatrician neonatologist down in Brazil and works at one of the largest neonatal intensive care unit in the country, who will be talking to us today about the vaccination in the era of COVID. Yeah. I believe I had seen Dr. Karam in. There she is. There you go. Thank you so much for joining us today, Dr. Karam. The floor is yours.
I think Dr. Walid could introduce me because he has my CV. Dr. Walid?
Yeah, he already introduced you, Dr. Karam. So the floor is all yours.
Okay. So Dr. Walid has my slides. First of all, I would like to thank this opportunity because making a bridge between the Lebanese doctors from Brazil with the Lebanese doctors in Lebanon and all over the world, this is amazing for us. Brazil has a lot of cases of COVID, so talking about the vaccines for us is something very, very solid because of the numbers. Also, I am working in this neonatology unity that has 100 beds. I had very big surprise to know the report of Dr. Elia. I love it, and I would like to speak with him about the cases we are following in our intensive care. 100 beds. Every day we have one case of asphyxia and a baby in the cooling, so we can speak together. So I will speak shortly about the vaccines in the era of COVID. And I would like to tell you that for us as a pediatricians, this is a very hard moment because it's the first time that we are in between of the social problems, ethical problems, family problems, and the indication as a doctor. So let's go next, Dr. Walid. So one of the most big problems we have with COVID now is that the kids are asymptomatic. So I will not take the words that our colleague made very properly about the sickness itself, but I will concentrate on the vaccines. But if we compare the sickness with the adults, especially kids up after 5 years old, we really have small symptoms. Next, Dr. Walid. So in Brazil, particularly, we in beginning of this December 2021, we approximately had the number of COVID in 22 million of cases. And from this number, we had about 617 deaths in Brazil. And our population studied the age of groups. And when we saw that kids between 5 up to 11 had a similar seroprevalence than in adults, we just made the role of the studies of the transmission, even with the less relevance of adults. Next, doctor. You can change for the next, please, Dr. Walid. Yes. In our country, we have about 34,000 hospitalizations that have been reported for the kids and teenagers under the age of 19 years old. This data showed us that the most attention and worries that we could make, it was attributed for 2,500 deaths. And our hospitals they were particularly rebuilt, and we were working hard and in a very good way, so the deaths become from the sickness itself. And the kids over the age of 5 and teenager they were responsible about 50% of the death. I would like to make a report of my own condition. This is strange that I have 50 years old, but I had the COVID as a kid. I have the multisystemic way of the sickness, and it was strange because I could feel in myself how the sickness behaved. And unfortunately, as Kawasaki, as myocarditis, as steroid, and obesity, all. So we know that the kids, they have the number is less, but when the sickness comes, it's really hard, and we keep the sickness longer. Now it's 1 year and 3 months that I had the sickness, and I still have symptoms. So next, please, Dr. Walid. The number of fatality of the sickness in Brazil is about 7% in kids. To understand the importance of the vaccine, we should think about the whole movement. That means that the kids, they are spreading the sickness between the adults. Is really hard because we must think about them first and then think about what is the relation between the sickness and the adults around. But unfortunately, we cannot stop the propagation of the sickness or the mutations that are coming out of it if they are not vaccinated. So the analysis comparing the problems coming out of the vaccine and coming out of the sickness itself, if we compare one symptom as a myocarditis, we can see that it will be 10 times more. So if we need to choose between the sickness and the vaccine, we will choose the vaccine. Next, please. We made a comparison between the way we were treating the vaccines in the past for meningitis, rotavirus, and influenza, And we discovered that the deaths coming out of this sickness, they were less than what comes from COVID. So in that time, we chose the vaccines. And this is the way we must think now, because we must think about the whole picture. And nowadays in Brazil, we are working with the Sinovac vaccine, and they are finishing the third part of the research to start the vaccine in kids about 6 months old. I am really, really sorry to leave you now, because it was a little bit late. This meeting should be on December. Then they moved it for today, and I am coming to Dubai today. I would like to just take the opportunity to keep one invitation for all of you as a fellowship or internship to come to our hospital to see this ICU of 100 beds. We have also one fellowship for plastic surgery for doctors from Lebanon. We would like to support doctors, new generation of doctors to come and try our medicine. And also, I would like to say congratulations for the Lebanese Medical Association of Brazil. They are doing a very good work. Dr. Robert that is with us today, Dr. Walid, Dr. Tufik, they are amazing. And Saha Group doing philanthropy also very good. And we would take the opportunity to make this connection between Lebanese doctors and Brazilian ones grow. I will leave my contact here, and if Dr. Elia could send me the information about Toby, I will be more than happy to try in our unity too. Thank you so much.
With pleasure.
And forgive me really, because it's my time to departure, okay? I will leave this study with you. Later on, we can share the numbers. This is the last research made by the Association of Pediatricians in Brazil and infectologists, and the numbers are huge. So this is something we can use for ourselves as an opinion, okay?
Thank you so much, Dr. Karam, and safe
Thank
travels.
you
Thank you so much for your time
much.
today.
Bye-bye, thank you.
Bye. Well, I guess we do have time for questions for Dr. Elia regarding our topic for HIE. If anybody, so one question that came up on the chat was regarding the limitations that we have back at home with providing cooling to our patients, and so what can be done about that, and what are your thoughts about using high dose thiamine in managing these patients?
Yes, so important question. Not just for Lebanon, but in many places where maybe this sort of high-powered, servo-controlled body cooling equipment or head cooling equipment may well be not available. The thing with asphyxiated babies, if we just leave those babies alone, if we do nothing to this baby apart from putting a bit of oxygen to their face, they actually drop their temperature, believe it or not, to 34.5 or 35. We just need to leave them alone. What we must not do is heat them, is warm them. A baby who's left alone or with a little fan by its side, we're effectively delivering whole body cooling. All we need is a rectal thermometer, which I think can be made available in most places, and to monitor their rectal temperature and make sure through using a fan, through using an open incubator rather than a closed incubator, through using things like cooling packs, but not in direct contact with the baby. Just make sure that this baby is not warmed up and the temperature stays down. We know that it's a safe procedure. We know that it should work unless there are other complicating factors. And in babies, a lot of the time, there are other complicating factors. I'd be interested to know, because I've never worked in Lebanon, about what actually happens in Lebanese units. What we found very useful here and I don't know if this is something that can apply to Lebanon, is to have like a cooling center. Like the whole of Lebanon can be served by one cooling center, where asphyxiated babies are transported to that place for cooling.
Dr. Malouf, this is what's happening kind of right now. So at the American University of Beirut, we have a cooling center with a very well protocolized procedure. But what's the challenges have been in transferring the patients and the monetary costs. So you get a baby who's born in a peripheral hospital that's 2 hours away. By the time you get the approval and you go through the bureaucracy of getting the money in and so on, sometimes the 6 hours, 8 hours has passed. And by the time you get them in, you worry when you don't get the outcomes expected, whether there was a delay. So there are a couple of centers who are doing it, but the economic situation right now in Lebanon is not helping in this at all. And you know, the cost of having different centers, maybe we should have regional centers that would be maybe more efficient. But right now the priority is shifting in medicine towards more making sure that we have the basic medications. I mean, I'm going to give you an example. We don't have epinephrine in the country right now. So this is as basic as it is. So I think right now, let's hope for the better. And let's hope that this is something we can work on to have regional in the different muhafazat, and maybe that would help a lot.
That makes sense.
But I have a lot of colleagues who are neonatologists with us who are attending, and maybe they can shed some light into what's going on in their hospitals.
Yes, Marianne, can I suggest that in those hospitals, while they're waiting to be transferred, that we do advocate and promote what we call passive cooling?
Yeah.
Which is please do not warm this baby and just leave this baby naked in an open incubator with a little fan next to them.
Yeah, and actually this we can come up as a recommendation from the Lebanese Pediatrics Society and make it just disseminate it across all. So it would be a very good suggestion. Thank you.
I would emphasize that as well. There is data to show that passive cooling, the initiation of passive cooling makes a difference in this kid. So, and that's what we even suggest for areas around our hospital here. I mean, even though we're in the US and so forth, we still have a lot of areas that have difficult access to the healthcare system. And this is one of our biggest recommendations, that they initiate passive cooling as soon as possible, because the sooner we can do this, the better the outcome. And then another important thing that I would say around the time of the event is also monitoring the rest of the metabolic derangements that happen. As Dr. Malouf eloquently mentioned, you know, that initial energy failure can be exacerbated by hypoglycemia, hyperglycemia, and so forth. So, you know, keeping a tight titration of all of these other components that are happening around that time until we can start cooling them and actively cooling them and so forth also plays a major role with helping out with the outcome of these kids. Another question that was brought up, Dr. Malouf, is one looking at the late pretermer, whether anybody has been looking at the use of cooling in the late pretermer, 34 to 36 weeks.
I'm not aware of any actual trials going on, but we all, through our own protocols, do allow ourselves to venture into that territory, but not too preterm. So for example, all the trials were done on more than 36 weeks. But if we do have a 36-weeker or even a 35-plus-weeker who has a classic story of asphyxia, we do go ahead and cool.
Yes, that's similar to what we've been doing out here in the States as well. There are some trials that might be coming up, and some of the centers aren't here in the country, also looking at the use of cooling for mild HIE. I don't know if your group or anybody has been interested in assessing its effect on those cases that end up being mild, but could eventually have an impact on your development.
Absolutely. I mean, we know that cooling is so safe, and there's so many trials going on at the moment, not just for cooling, but as you know, for things like magnesium sulfate, eoprotein, like other factors that may be added to the cooling process in order to maximize outcome. And we had a lot of discussions about mild cases of asphyxia If in doubt, I would cool. It's as simple as that.
Exactly. Another question brought up is regarding the role of the EEG as a prognostic evaluation tool.
EEG is extremely important, and we get EEGs on all those babies. But of course, in order to get a proper EEG, you need to do it during working hours, during weekdays. It's not a bedside tool, but of course, CFM is a bedside tool that can give us a huge amount of information. But we do EEGs on all these babies, and EEG is a great prognostic indicator.
Agreed. So we use an amplitude EEG out of the bedside as a tool, especially in the middle of the night where sometimes it's hard to get an EEG to come in place. And I agree with you. I mean, many kids we've been able to start cooling just based on the fact that we pick up on seizure activity using the bedside tools versus when they don't meet any other criteria that come up.
Yeah, what we must remember, Naif, especially regarding your question about the mild cases, is that this staging of HIE is not a sort of one point and that's it, it's finished. Baby who is in stage 1 and point 0 may well turn into stage 2 or 3 hours later. So it's a dynamic thing that needs to be assessed all the time, which is why it's better to cool when in doubt, even for mild cases.
100%. One other question that I had that I think some of us have struggled with is, so I think we can all agree with the fact that getting an MRI post the first 72 hours of birth is better because of the edema that happens. You want that to resolve. But I think the question when it comes to prognosis has come, how soon after the 72-hour of cooling does one get the MRI that will provide the best information for families as far as prognosticating?
What we don't know is how these classic signs on MRI will be affected by cooling. So I wouldn't be brave enough to give a bad prognosis if I see basal ganglia changes, let's say on day 4, in a cooled baby, because we really don't know how cooling is going to affect the final outcome. So I know parents want to know, and the most important thing for them is, you know, what's my child's mental development going to be like when he's 15 and 20 and at school, etc. That's going to be impossible to answer, regardless of findings on MRI.
Exactly.
So the best timing to do the MRI is when all the brain swelling had gone, and I would say about 7 days of life, unless we are talking about withdrawal of care. And then we may want to get the MRI done while a child is ventilated in order to help us make a decision.
100%. One question that wasn't answered earlier was your opinion regarding the use of high-dose thiamine for these patients.
Experimental, not proven. It's part of a whole array of medications that are being trialed. Again, unless we have, like we had in cooling, even with cooling, as you can see, 3 international trials, each one of them showed a non-significant outcome. So thiamine is, you know, is just a trial medication at the moment. I cannot recommend it for routine use.
Perfect. And then another question brought up was cooling, light cooling in the UK, if it's something that you have practiced or have experience with.
Which cooling? Sorry, I missed that.
So I get my understanding from the question would be, I guess, cooling those that go beyond the 6 hours, whether there's any benefit from it.
Yes, of course. We should do passive cooling as quickly as possible. But let's say a baby was born, nobody suspected that there is HIE, and then at 7 hours, the baby had a convulsion, and then when reviewed the history and when told, oh yes, we do have criteria A, we do have criteria B, should we cool even 8 hours? I would still go ahead and cool.
I guess they were being more specific at 96 hours.
At 26 hours.
That's 96.
96. Whoa. That's a bit way. No, I wouldn't. I wouldn't cool at that stage. No. Would you?
Oh.
Naif?
No. I think again, based on the physiology of what's going on with the brain, I think if you're waiting that long, yes, you're going to be late in the game.
Yes.
You're dealing with irreversible damage at that point. Then one question is the possibility of cooling babies who have a cardiac issue. Of my understanding, there's no contraindication. I'm not sure if you're aware of anything.
Well, the one thing that we find cooling exacerbates greatly is severe persistent pulmonary hypertension of the newborn. So those that actually have asphyxia and are ventilated in 100% oxygen, we find that cooling exacerbates that, and we've had cases where we actually had to stop cooling in order to be able to oxygenate those babies. But cardiac babies, no, we continue cooling cardiac babies. In fact, I think they're cooling cardiac babies on PICUs with ECMO, like ECMO babies and the cardiac surgery babies. They're being cooled on PICU units.
Yes, and we will do it as well. If the kid ends up with severe pulmonary hypertension that requires ECMO, we will do the same with running the ECMO circuit and cooling them at the same time. I think those were the questions that we have. Any other questions that the group might have for Dr. Maalouf? Very, very good question of controversy. What would be the anticonvulsant of choice for this population? Do you think?
That is very, very, very controversial, and I am sure that each unit has got its own policy. We always, over here in the UK, I'm sure you do things different in Lebanon or in the USA, we always load with phenobarbital first. But that's just a UK policy.
I know, we're stuck with, go ahead, I'm sorry.
Yeah, we load with phenobarb. We can then go to things like clonazepam or even midazolam, depending on how resistant these convulsions are. We've used Keppra as well in newborns with resistant seizures.
Yeah, no, we were stuck with phenobarbital as well, although Keppra was being pushed by our neurologist colleagues as well. But I think there's data to show that phenobarb, just because of how readily available it is and so forth, it's always a better choice to start with.
Yeah.
All right. Well, looks like this is it.
Excellent. Very lively discussion.
Yes. Dr. Majalani, you want to take it over, or should I?
I think Dr. Ahmar wanted to do the concluding remarks, him and Dr. Bakhash, but I think it was a very nice exchange of science between us across the globe, and I'm looking forward to having more webinars of this sort. So thank you again for Dr. Bakhash and Dr. Ahmad, and meeting all of you, although it's remotely, but it was really amazing. Thank you very much.
Thank you all. Thank you for inviting me.
Thank you, Dr. Maalouf. Dr. Bakhash, the floor is yours.
Thank you. So Dr. Ahmar, if you can conclude before presenting the next webinar.
Thank you very much, Dr. Yusuf. I concur and totally agree with Dr. Marian. The caliber of the speakers was fantastic, and we hope to continue these educational webinars. It is our honor and privilege as doctors of Lebanese origin outside of Lebanon to participate and to partner with the Lebanese Order of Physicians within Lebanon and the doctors within Lebanon. And I think it's important we form collaborations, networking, as it was invited by Brazil, our English doctors and the USA doctors and other doctors and groups as part of ILMA. We span the globe, and we want to assist you in any way possible. And I think by continuing this collaboration, as Dr. Yusuf will announce the next series, we will form closer linkages, and we are here to partner you. We are here to collaborate and to assist and build both our knowledge base and learn from each other. And, you know, hopefully, and we pray that Lebanon comes through this difficult and dark period and comes a better and a stronger country, not only socially, but also medically. And I thank Dr. Yusuf, once again, Dr. Sharaf Abi Sharaf, Dr. Marianne, who's worked with us in this agenda, our other co-moderator, Dr. Naif, for his time, and the three excellent speakers. Thank you very much. Dr. Yusuf.
So thank you, Walid. May I share my screen, please? Okay. So I would like to thank, first of all, President Sharaf Abu Sharaf and all the Lebanese Order of Physicians boards for all their efforts they are giving to promote education in Lebanon. Also, I would like to thank ILMA and its president, Dr. Walid Ahmar, for his unlimited support to all teaching and medical educational projects in Lebanon. I would like to thank the Lebanese Pediatrics Society for its participation today. Many thanks to the two moderators, Dr. Marianne Majdalani and Dr. Naif Shaheen, to the speakers, Dr. Manuela Lahoud, Dr. Elia Malouf, and Dr. Salam Karam. And now I will be waiting to see you again in 3 weeks on Wednesday, February 2nd at 7 p.m. with our first webinar dedicated to the orthopedics surgery and organized with the Lebanese Society of Orthopedics in updates and innovations in orthopedics. So hope to see you again in 3 weeks. And I am wishing to you a good evening and a good night.
Well, I think this concludes our time. Thank you all, everybody, for attending, for having us today.
It's a pleasure. Thank you, Naif. Thank you, Yusuf.
Thank you, Naif. Thank you, Marianne. Thank you, everybody.
Well, our pleasure. Hope to host you in Lebanon live soon. Bye.
Yeah.
See you.
We also need to thank Dr. Miriam Miso in Sweden for the behind-the-scenes work on the running the show, the slides. She does an amazing effort for every series. So thank you very much, Miriam.
It's a pleasure, Dr. Ahmad.
Have a wonderful evening.
All right, you all do
Bye,
the same. Take care.
bye, bye.
Bye.